Okay, welcome everyone. Good evening. For those who don't know me, I'm Allison Vickery and I'm Vice President of the Alberta Lymphedema Association. Myself and the rest of the board are excited to welcome you here tonight for another lymphedema night, where we are joined by a very special guest speaker, Siba Haykal. Dr. Haykal is a plastic and reconstructive surgeon, clinical investigator, assistant professor at the University of Toronto. She will correct me on any of this if I'm wrong. She serves on the board actually for the Canadian Lymphedema Framework as well, and was named one of Canada's top 40 under 40 in 2021. If you Google her, she has a very extensive clinical and research profile, but tonight she's here to talk to us specifically about surgical techniques in lymphedema and her ongoing research in this area. So just a note that we will hopefully have some time at the end for Dr. Haykal to answer questions. So please feel free to put your questions and comments in the chat in the meantime. And without further ado, I will pass it over to you.
Thank you so much, Allison, and thank you for the invitation to present today. I'll share my screen. Allison, maybe you can let me know a little bit about my audience.
Sure. So we do have, I closed the sheet, but we do have members in the audience, which includes therapists, medical professionals, a lot of patients typically. Excellent. So people do have a base knowledge usually of lymphedema, but we're always looking to learn more about what research is telling us and about new treatments and things like that.
Okay, thank you. Welcome, everyone. I'm excited to join all of you today, and please feel free to also interrupt me if you have any questions during my talk. This won't take an hour. Hopefully, it's a very short presentation, and there's a lot of room for questions. So the objectives are really to look at which patients would be candidates for surgical management of lymphedema. What are the possible options for surgical and microsurgical management? What are the preoperative and postoperative rehabilitation protocols that we use? And what are potentially the future techniques that we are looking at specifically for prevention, but also what is happening in the lab right now? So the pathophysiology of lymphedema initially starts with acute lymphedema, where there is generalized protein and fluid accumulation, which leads to inflammation and some dilation and fibrosis of the lymphatic vessels. This eventually leads to chronic lymphedema, which is a sustained inflammatory response, which also eventually leads to an increase in excessive adipose tissue, fibrosis, and further dilated and fibrosed lymphatics. The management, as discussed with all of my patients, is that it starts at the time of cancer diagnosis. And I say this because I mainly see secondary lymphedema, although I do see some cases of primary lymphedema. Most of the time, I am a cancer surgeon, so I am referred patients who have had either node dissection and radiation. And really, this focuses on prevention and surveillance. So early assessment is key, and I cannot stress that enough. Referral for exercise and rehabilitative therapies, early physiotherapy, and we know that that is cost effective because that reduces the burden associated with things like hospitalization and infection. It also centers around education, which is promotion of positive self-efficacy strategies that really reinforces the ability to control the lymphedema through early detection and early referral. So combined decongestive therapy, as I'm sure most of you know, really centers around two modalities, actually more than two, but really manual lymphatic drainage. So there are multiple techniques with multiple articles that have been published on the effectiveness, and really depends on the training of the therapist, and also compression. And the goal of compression is to reduce the venous pressure and therefore allow for the outflow into the interstitium and really encourage the uploading of the lymphatics by virtue of tissue pressure, variations, linked to any form of muscle movement. So this takes on the form of bandages and then garments. In the first phase of CDT or CPT, the goal is for size reduction of the affected limb and improvement of the skin. And in phase 2, it's really an ongoing individualized self-management regimen with the use of low stretch elastic bandaging or any form of sleeve compression, with multilinear inelastic and controlled compression therapy, because we know that they reduce volume. The goal is to decrease the swelling, to increase the lymphatic drainage, to reduce skin fibrosis, to enhance the functional status, to really relieve any discomfort or pain, and to reduce the risk of cellulitis or infection. Staging in lymphedema is important, and there are several different staging modalities that are used. In my clinic, I use the 2013 consensus document of the International Society of Lymphology. It focuses on 4 different stages. Typically, stage 0 is subclinical. There's absence of edema in a risk development patient. Those are not typically the patients that I see, but we are starting to pay attention a little bit more as to who is actually fitting in this category so that we can see them early and really start the work early. Stage 1 is the presence of edema, and I've learned from my therapist that pitting edema is good because we can reduce pitting edema, and that can be reduced by CDT or CPT. Stage 2 is edema that is partially reduced by treatment, and there is no pitting edema. For both stage 1 and stage 2, the surgical techniques that are available are physiologic techniques, and I will discuss those in further detail. And in stage 3, we have what we call lymphantiasis with skin lesions and relapsing skin infection. And the surgical modalities that are available for that stage are liposuction or ablative techniques. These are examples of the stages that I just discussed. And these are what the skin actually looks like. Initially, we have mild skin changes, which are reversible and associated with high protein edema, which eventually lead to spontaneous, irreversible hardening of tissue. Patients will experience dry skin, discoloration, and hair loss, and elevation is no longer helpful. And in severe cases, such as elephantiasis, there is extensive hardening of tissue and fatty tissue formation, and this leads to further skin changes. When we look at the lymphatic vessels under the microscope, it's also quite distinct between the stages that we see. In a normal lymphatic, which is also present in stage 0, the lymphatic vessels look normal. They are thinner, they are not dilated, and there's good flow within these vessels. However, when we look at stage 1, there's what we call ectasia. So the vessel looks more dilated. Eventually, that vessel thickens and contracts as seen in stage 2. And there's narrowing of the lumen of the vessel with increase of the other layers of the vessel. And eventually in stage 3, we see sclerosing of the vessels. Whenever I see a patient in the clinic, the most important thing is to perform imaging. And imaging centers around 2 different techniques. The first one here is lymphoscintigraphy. My clinical examination is key because that allows me to determine what stage they are at, following which I perform a lymphoscintigraphy. A lymphoscintigraphy is imaging where there's an injection of a radionuclide agent in between the web spaces, and then the patient is imaged to look at the lymphatic vessels. And typically what we see in stage 0 is that there's normal lymphatics and the lymphatic vessels are draining into the nodes. In stage 1, there's initially what we call dermal backflow. So there are some lymphatics, but the nodes are visualized. In stage 2, there's severe dermal backflow. And in stage 3, there's complete obstruction with no backflow and no visualization of the nodes. Also, another modality that I use, and I use this in the operating room as well as in my clinic, is the injection of a fluorescent dye called indocyanine green. This is also injected in the web spaces, and we can visualize the progression of lymphedema. In a normal lymphatic vessels, there's what we call linear flow, and then abnormal with progression of lymphedema, it ranges from a splash pattern to a stardust pattern and to a diffuse pattern. And that is an important modality. So this is an example of a patient that I've injected in the operating room, where we see around the finger area, there's presence of initial linear flow, followed by eventually lack of any further flow above the elbow. And we can see that this ranges from stardust to splash to stardust to diffuse pattern. So intraoperatively, I use these patterns, and I use them quite frequently because they are important. They allow me to really determine where I'm going to make my incisions. And these incisions are placed in an area where I can potentially find some lymphatic vessels that are still working. This is an example of a lymphovenous bypass. So multiple incisions are made around the area where I think the lymphatic vessels are still working. And then a blue dye is injected a bit distal to each of these incisions. The blue dye will actually stain the lymphatic vessels, as you can see here on the right-hand side. I then open the lymphatic vessel that is stained in blue, and I look to see if there's any outflow from the lymphatic. If there's any outflow from the lymphatic, I know that this is a working lymphatic. I then find a small vein, which is called a venule, right underneath the skin. And then I open that venule, and I make sure that that venule has very little flow, and I'll explain why later. And I perform a bypass, so that means an anastomosis or suturing of those vessels. These vessels are less than 1 millimeter in size. They're about 0.7 millimeters in size. So I use a microscope to do this, as well as very, very small sutures. So how does a lymphaticovenous bypass, or LVA, work? So this is a microsurgical anastomosis of an obstructed lymphatic vessel, or it's obstructed much further along, to a small superficial vein to shunt the lymph fluid into the venous system. And the theory behind this is that the lymphaticovenous anastomosis is going to remain patent and open if the lymphatic pressure is higher than the venous pressure. And this is really best endured and ensured by making sure that the anastomosis is performed to a low pressure subdermal venule. We believe, and looking at studies, that the reduction of the volume is about 34.5% at 1 year. Another modality which can be performed in stage 1 and stage 2 is a lymph node transfer. So this is a bit more complicated, and it involves going into the recipient vessel of the lymphadematous extremity and preparing it by first excising the scar. So that's followed by taking a flap of tissue containing some lymph nodes, so superficial lymph nodes. Those lymph nodes can either be taken from the omentum that's in the abdomen, from the groin area, from the thoracic area, so around the neck and the chest, and also commonly from the abdomen. And these are taken, it's a tissue taken with vessels, so both an artery and the vein, and they're disconnected from the area, and they're reconnected in vessels that are located in the arm or the lower extremity, depending on where the lymphedema is. So the theory behind this is that we are transferring healthy lymph nodes, and they will produce vascular endothelial growth factor. So that is a factor that promotes lymphangiogenesis, which means the formation of new lymphatic vessels. It also allows for the connection between proximal lymphatic vessels and distal lymphatic vessels. Preparing that area ahead of time by removing the scar tissue, that usually blocks that lymphatic flow can actually help enhance the function and reduce the development of infection. And it really serves as an interface between the lymphatic and the venous system without actually creating connections. There's actually no data that suggests that the lymphatic vessels really regenerate from the transferred nodes. So the way these nodes are behaving and working is that they're producing growth factors to allow lymphatics that are in the area to create new connections. This is a preventative technique. So this is a technique that is exactly the same as the lymph node bypass that I described in a patient that has lymphedema. However, this is performed as a prevention. So this is performed in the case of patients who are either undergoing full groin dissection or full axillary node dissection, commonly in breast cancer patients. And in this case, we are performing small little shunts, exactly the same as described for the lymphovenous anastomosis technique. However, this is done in a patient that does not have lymphedema. This is the algorithm that we use. So whenever a patient is seen, the first phase is we make sure that there's appropriate CPT or CTT for at least a period of 6 to 12 months. Following which, in the phase 2, we would perform a microsurgical technique. And in the phase 3, we begin post-operative rehabilitation and a minimum of 5-year follow-up to see whether or not they've developed any lymphedema. What are the indications for lymphatic surgery according to the protocol? So I talked about some preventative techniques that we perform. The other thing is to make sure that the ablative surgeon or the surgeon who's doing the dissection is very cognizant of the fact that there's minimal disruption to the lymphatics in the area. Then, in terms of treatment, multiple lymphovenous anastomoses are reserved for the early phase. And in the late phase, things like liposuction, when adipose tissue or fat tissue begins to accumulate, and excisional techniques. So there's a lot of what we call excisional techniques that have been described. Those include removing excess skin and fat from the extremity, and either using skin grafts to cover directly over the muscle. We know that these techniques don't actually work really well because we have not changed the underlying pathophysiology or the underlying issue that has led to lymphedema. So typically what would happen in these patients who have had these surgeries is they either would develop lymphedema in the foot, or, for example, in a lower extremity, or in the hand, in the upper extremity, or anywhere more proximal. And it is common that there's a lot of complications associated with these types of surgeries, including chronic wounds and delayed wound healing. We have developed, along with our therapists, a very rigorous assessment to determine whether or not the patient is appropriately fitted for compression in a sleeve prior to surgery. We also use very particular calculations of arm volumes from circumferential measurements. 2 weeks prior to surgery, patients begin 3-layer compression, and we determine the amount of time that they usually spend on lymphedema care on a daily basis. Post-operatively, it really depends on the technique that we use. There's quite a lot of difference between lymphovenous bypass and a lymph node transplant. In the case of a lymphovenous bypass, there's a 6 weeks of compression, followed by gradual transition back to the sleeve. There's changes in the massaging protocol, where we start massaging towards the anastomosis or the bypass. And the goal of that is that this is a low flow to a low flow system anastomosis. So in order to maintain the anastomosis open and patent, we have to actually provide it with some form of compression. And the massaging towards that anastomosis allows us to do that. The goal is to eventually decrease the amount of time of compression and the amount of time that each patient spends on their lymphedema care. With regards to future directions, we actually have quite a lot of work done in this area. Particularly, there's a lot of basic science research, and we have enrolled a lot of our patients in some of this research. This involves looking at the inflammatory markers that are particularly present. We've identified two inflammatory markers that are definitely common in patients with lymphedema. We've analyzed some tissue and some fluid that we procured during the surgeries. And our goal is, and we've done some molecular analysis on them as well. And the goal is to really create new therapies, new drugs, new pharmacological techniques. We know for sure that there's probably an underlying either RNA or DNA component, in the sense that not all patients who undergo radiation or node dissection secondary to cancer will develop lymphedema. We know that there are some genetics that are really associated with that as well. So that's a brief sort of overview on some of our research. I want to thank you very much for having me today, and I welcome any of your questions.
Thank you so much, Dr. Haykal. Nothing coming in the chat yet. Anyone can feel free to type in their questions, or just, unmute yourself if you would like. I do have a lot of questions. If it's
Sure.
okay, I'll start while we're waiting for others. In terms of the shunts for prevention, that's really amazing. I know that it seems like only relatively recently people have even known this was a risk factor when they're going through breast cancer treatment. So I'm just wondering how common this surgery is, and how many people in Canada are actually performing that surgery.
Yeah, so it's actually quite common in the US and Europe that they've been doing this for over 10 years, or they do it as a preventative technique. I myself have been doing it for about three years. And we actually have a randomized controlled trial right now where we're going to randomize all breast cancer patients who are undergoing axillary lymph node dissection into a LYMPHA. So the technique is called LYMPHA, and it stands for Lymphaticvenous Bypass Preventative Healing approach. So we're going to randomize them into the LYMPHA versus the non-LYMPHA. So we have a few grants and a few projects going that way. There's also actually a big cohort in Alberta. One of my colleagues, Dr. Claire Temple-Oberly, has been doing this for about 2.5 years. She probably has one of the largest cohort of patients that she's actually done the preventative techniques on. She doesn't perform lymphovenous bypass for patients with lymphedema. She only performs the preventative techniques. And I actually have invited her to come speak at the Canadian Lymphedema Conference in November, and she'll be there. And she'll talk about her series, I believe, of about 60 patients, where she's actually, and because she's followed them for up to 3 years, she's actually shown a reduction in the incidence of lymphedema. The issues related to I'm a big data person. I'm a numbers person. I think it's really important to stay on top of that in order to really be able to provide new treatments. So the most important thing to know is what are the rates of lymphedema in somebody's practice, right? Or at a particular site. And unfortunately, those rates are not well known because sometimes patients are just not followed. They're not followed long enough, especially post-cancer surgery treatment. So I think the longer that we follow them, the more likely we'll be able to know what exactly are the lymphedema rates, and are the modalities that we're using, such as being a bit more cognizant of how we do the dissection, performing the preventative techniques, are we actually reducing the rates of lymphedema? So in the US and in Europe, they've shown that there's been a reduction from 20% to about 5%. A 20% risk of lymphedema is quite high, actually, which is not necessarily our rates of lymphedema here. So I think if we can quantify that first, or at the same time, we can kind of run these studies in parallel.
Very interesting. Yeah, no, it makes sense. And I am going to the conference in Toronto, so I'll be sure
Great.
to tune into her talk. Yeah.
Awesome. Yeah, we'll have a whole panel on surgery and lymphedema. So we have a few invited guests, and it'll be great.
So this is Diane speaking. I have one question well, I have a lot of questions, but you do not have time for all the questions I have. But, when you're taking from a lymph node from, I take it you take it from the other arm, or
No.
you take it from another person?
No.
No.
No, you take it from the same person. So you can't take it from another person unless you have an identical twin, or it will actually be rejected,
Okay.
right? It would be like a normal transplant. So you actually take it from the same person. You don't take it from the opposite extremity, because if you do that, there's actually a high risk of developing lymphedema in the contralateral limb. So the areas that we take it from are areas, so first of all, there's different modalities. The least invasive area with the least chance of developing lymphedema is to open up the abdomen and take a piece of what we call the omentum. The omentum is basically tissue which is composed of some fat that surrounds some of our stomach, intestines, etc. And you take it along with the vessels. So that's the most common, but it involves like actually opening the abdomen. So I'm working on some techniques to actually do it laparoscopically, like with a camera and small incisions, so that patients don't have to do that. So that would ideally be my first site. The second site, which actually I prefer, it's a little bit easier, but does require what we call reverse mapping. So reverse mapping is basically mapping out the lymph nodes which actually drain an extremity, and making sure you don't take those, because you don't want to induce lymphedema. So one of the most common is called a skip flap. So a skip flap is basically a flap on the lower, close to the groin, but right above the groin, where the abdomen is. It's based on small little vessels called the superficial epigastric vessels. You take the vein and the artery, and you take skin and fat underneath, and you actually travel all the way to include some of the lymph nodes that are really close to the groin. So right now, that is the most common flap used for the lymph node transfer. And it works really well. It's a smaller incision. The incision is well hidden. It's a good donor site. Your chances of inducing lymphedema are very, very low. So that's the most common site currently. So people have taken it from other areas, such as like submental, supraclavicular, thoracic. The problem with those areas is you can actually induce lymphedema in those areas.
Yeah, that's why I asked the question, because I've heard of a few people being a little worried that if they take it from the arm that does not have lymphedema,
yeah, that would not do
that. So, okay, and
yeah, never.
Okay, and my other question, and I'll let the rest of the people ask questions. Do you a lot of people think that they do not ever have to wear compression after surgery, but I've been told from a couple surgeons is that no, you still continue to wear your compression after surgery.
Yes. So the goal is so I never tell a patient. So first of all, when I see somebody, I tell them there is no cure for lymphedema. Okay. The goal of surgery is to actually reduce the chances of going from an earlier stage to a late stage of inducing chronic lymphedema, to prevent the chance of, to prevent further infections, to plateau the volume increase, and to decrease your symptoms. Because a lot of patients also have many symptoms related to pain, but everything else. So heaviness, difficulty with, activities of daily living. So I never say that you will no longer need compression, because I know that genetically I have not changed the reason for the causes of lymphedema. So I think anybody who is telling patients that they will no longer need lymphedema, I would be very, very cautious, okay? I have had patients who have either gone elsewhere, outside of Canada, who have actually obtained that advice, that they will no longer need compression. So I don't believe that. Yes, you still need compression, but our goal is to hopefully reduce everything that I just talked about, but also, you know, maybe not do compression like 24/7, maybe be able to kind of reduce the amount of compression that is needed. Every patient is different, and every patient like behaves differently, even following surgery. So I think it's important to kind of be cautious and really like work with them and to see what works and what doesn't work. And typically patients who are good candidates for this surgery, they really know, like they've done it all and they've done a lot of it. And they're very conscious about what needs to be done. So yeah, I would never say that compression will never be required.
Thank you.
Yeah, it's really interesting to think about how everything kind of fits together, just because a lot of this is preventative. So it goes hand in hand with, you know, reducing delays in people getting diagnosis and treatment in the first place. And obviously being aware that this exists as a risk factor, obviously in the case of the LYMPHA.
Yeah.
Yeah.
Absolutely.
It's very hopeful.
Yeah, I think you know, it's interesting. I work in a highly academic center. You know, I've been there for almost 6 years, and we've been really pushing and promoting. And there's definitely like one breast surgeon who is really on board. And now, like everybody else has kind of started, it just takes a little bit of time for change. But I think as long as you keep advocating and pushing for it and to show people how important it is. I think Teresa has 2 questions.
Teresa, do you want to ask the questions?
Maybe she's typing. She's shy today.
Oh, good.
But feel free to unmute yourself if you'd rather.
Sure. Can you hear me?
Yes.
Yep.
Hi. Thank you for all the information, Doctor. I'm just wondering, is there a list of surgeons in Canada who are currently performing any kind of surgery for patients with lymphedema?
Mm-hmm. Yeah, there's a list. And we have a list as part of the Canadian lymphedema framework. And I'm actually putting together like a national surgical consortium as part of the Canadian lymphedema, the national conference, where I've invited a lot of those surgeons to kind of participate and really like for us to maybe like do a bit of strategic planning and put together some sort of guidelines and things that we really want to make sure we provide our patients, and for a lot of us to kind of agree on, you know, what we can offer and cannot offer. There is a list. If there's a particular province that you're interested in, I'm happy to send you that information. And maybe I can tell you who those people are. There's definitely some people in Alberta. Dr. Temple Oberly is definitely someone there. The group in Calgary there as well. She has a few of her colleagues, but even emailing her is totally fine because they can refer you to someone there. And then there's Dr. Mo Momtazi, actually left Ottawa and now is in Edmonton. And he did a lot of the lympha procedures in Ottawa as well.
Okay, that's great. And would those be for appropriate for people that already have lymphedema rather than preventative?
Mm-hmm. Yeah, absolutely.
How would you assess if after having lymphedema, like in my personal case, I've had primary lymphedema in my lower leg for 25 years. How do you assess if it's worth the risk of having surgery or not? Yeah,
so the assessment is based on 3 things. So 1, clinical exam, and really going through your history and examining you. The other thing is doing a lymphoscintigraphy. I've certainly operated on patients with primary lymphedema, and The third modality is to do ICG lymphangiography, because that really helps us map out. It's interesting, the patterns that I spoke about in secondary lymphedema, or even like the linear to the splash or the stardust to the diffuse pattern, it's so variable and different in primary lymphedema. And I find that like really, really interesting, because I've seen cases where it's linear, then splash or stardust, literally you see like a star, and then it goes linear again. So there's a lot of like different patterns, and it's super interesting. But definitely at least getting ICG lymphangiography is a good place to start.
Okay, thanks.
You're welcome.
I think for the list of surgeons, if you want to give that to us, we can probably link to the CLF list
Sure.
from our website as well for our members.
Great.
We can add that.
Sounds good. I think, as a group, like the framework is really working on putting an up-to-date list. Right now, it's like a Google Drive between me and like the executive director, where we're like populating. And even like then I really searched many of these surgeons and who used to at least do it, and now they're completely cosmetic. So it's been a little bit, it's been a bit of struggle. And part of the struggle is also related to resources. So most centers do not have the appropriate resources or funding to be able to do these surgeries. They're very extensive. They require a lot of resources, which are expensive. The surgeries themselves take a lot of time. So I'm a microsurgeon who really does 10 to 12-hour cases every single week. So for me to book a 5-hour case, that's really not that big of a deal in my center, right? But in other centers, potentially that could be a barrier. The other thing is like funding strategies. So I've had to I'm now like the Ministry of Health, for at least for Ontario, the representative that tells them whether or not patients should be traveling to the US to be getting some of these surgeries. And before that, they didn't even pay for these surgeries. Like they didn't even pay the surgeons to actually perform these surgeries. And I continue to kind of like struggle with them to actually be able to offer them to patients, because paying out of pocket or going to the US and paying an exorbitant amount of, money, I think that's really wrong. And I really don't think that we should do that. So if anybody's ever interested to tackle on the political part of this, please call me. Because I don't have time, but I need somebody who has a really strong voice, who knows how to push things along.
I know that in Calgary that we do have Dr. James Kennedy that does surgery, and Alberta Health Services does pay for it, I believe. So, and we had Alberta Health Services pay for treatment. We went to the health minister and got that through. Yeah. So, and
amazing.
Our provincial chairs have put together a list of surgeons for lymphedema.
Great.
I can send that to you if you would like. I think that Bonnie was trying to get us,
yes,
helping us work on that. So I can send that to you, and when we get your list, we'll just combine them and put them up on the website for you.
Great. Yeah, anybody you can send me. I also would like to have them come to the conference so that we can really get together and talk about goals. So
yes, yeah, that's for sure. Is there anybody else that has any questions out there?
I have one more question.
Sure.
I just read a story yesterday, an article that said that lymphedema patients are at risk of developing sarcomas. And it's the first time I've ever read that. Is that true?
So there is a rare form of sarcoma called lymphangiosarcoma. It happens in patients who have chronic lymphedema, but not every patient who has chronic lymphedema develops lymphangiosarcoma. So very similar, yeah. And the syndrome has been written by Robin in the actual chat. So it is rare, and it does not happen. It's also that syndrome patients have lymphovenous malformations, and they have there's an issue related to the way I've seen it in clinical practice. I've actually seen it a few times. And I've even seen cases of lymphedema from filariasis and everything else. So, but yeah, so it's actually quite rare. And we believe there's an underlying genetic component. So not everybody who has chronic lymphedema develops that.
So it's more genetic than anything else.
Yes, absolutely.
Okay. Yeah, it's the first time I'd ever read that. I didn't know there was any, if you have non-cancer related lymphedema, I had never read that there was an increased risk of a certain kind of cancer due to lymphedema.
Yeah, unlikely. Unlikely. There would have to be like an underlying syndrome. And that's usually more than just lymphedema.
Okay. Thank you.
You're welcome.
Peggy.
I was going to ask, I have lymphedema, and I had surgery, mastectomy in 2009. And after I had a little bit of lymphedema after the surgery, but after I had radiation, it just really came out in my arm and that. And with exercise and the lymphedema garments and everything, I kept it under control. But the last 2 years, I've been getting infection, swelling, and antibiotics, and it keeps growing in size. And I don't know what I can do to bring it back down, like, because my garments keep getting larger and the compression keeps getting higher. And I just went a round of 10 days of antibiotics, and that helped. But I don't know what's causing this, you know. It's just kind of frustrating, you know, when you're doing what you think you should be doing, and this is happening.
Yeah. Yeah, Peggy, I don't know if I have any answers for you as to why this is happening, but I think I'm not sure if you are, you know, you have a multidisciplinary team, like any therapist or family physician, really following you for that and doing like serial measurements and proper fitting, you know, the whole appropriate skincare and everything like that. It's a whole multimodal approach. Surgery, if you're asking if surgery is, you know, the treatment for you, again, surgery is just one of many modalities, right? And surgery would not, you know, with somebody who's potentially had multiple infections, I wouldn't say that surgery is necessarily ideal. So I think the best way to answer that is to really have somebody examine you, stage you, perform a lymphoscintigraphy, you know, to see if there's any working lymphatics, and really making sure you have all the appropriate members of the on your team. Okay.
If there's no more questions at the moment, we can probably say thank you to Siba Haykal for joining us tonight and giving us that really informative presentation. I definitely learned a lot. I still do have a lot of questions, but I think that we've grilled you enough, and it was definitely very interesting.
Thanks so much for having me.
Thank you very much.